nerve. Thank you. The next portion of the examination is looking at range of motion. This should be checked not only anteriorly but also posteriorly. Anteriorly, we check for scapulohumeral range of motion. However, this is a rhythm. We want to make sure that the shoulder as well as the scapula are rotating normally. This is probably best evaluated with a patient turning posteriorly. And again, with abduction of the shoulders, you can see the normal scapulohumeral rhythm, and you want to compare both sides. In regards to range of motion, we're also looking to see if there is a painful arc of motion that can usually occur between 70 to 110 degrees of shoulder forward flexion, as well as forward flexion, which can cause pain right at about this level, as well as with abduction at about painful arc of motion could start occurring at this level, and usually that signifies impingement syndrome as well. At least it's one of the tests we look for, as well as looking for any rotator cuff type pathology. The range of motion is checked again in forward flexion. This is the range of motion in the sagittal plane. With the arms to your side, that's 0 degrees. However, with your arms all the way in forward flexion completely, you can see Dave has about 160, 170, and there we go to 180 degrees of forward flexion. Back down. And again, abduction is the arms going away from the side of the body in the coronal plane, and you could see 180 degrees or so of abduction there. Rotation of the shoulder is usually examined both with the shoulder at 0 degrees of flexion as well as at, of abduction, as well as 90 degrees of abduction. So initially we would ask the patient to put both arms like that, and then we'd ask them to externally rotate, and you want to see if this is symmetric. In cases of adhesive capsulitis, the patient would only be able to externally rotate just mildly as compared to being able to externally rotate all the way on the other side. The best position, though, to examine external rotation is both arms, again, at 90 degrees of abduction, and then externally rotating, because that's a position that is most commonly when the shoulder is injured, for example, like in a throwing type athlete or in racket type sports. Now I want you to turn around. With the rotation, we're also looking for internal rotation, and the best way to do this is called Apley's scratch test. Basically, you're asking the patient to scratch as high up on the shoulder as possible. So you test one side, then you ask them to bring the arm down and then do the other. Many times what you find patients doing is that if they're unable to internally rotate very much, they get their other hand to grab this one, trying to lift it up, which is not the right thing to do. Okay. The other examination with the rotation is being able to perform a cross adduction, where we want the patient to be able to cup his hand across the other shoulder. Again, the next portion of the examination is palpation. Again, we went over this with the inspection, but again, we are looking at the clavicle, at the sternoclavicular joint, the acromioclavicular joint, the coracoid. We're looking at the deltoid as well as the pectoralis major. The long head of the biceps tendon is usually palpated in this area in the intertubercular groove region. Again, the acromion is felt on the lateral aspect of the scapula, and if we are attempting to palpate the deep portion of, attempting to palpate the subacromial bursa or subdeltoid bursa, this would be in this region. And again, we've discussed earlier, palpating across the trapezius as well as on the rhomboid region of the shoulder. Is looking at muscle testing. We want to test the scapular stabilizers. Again, like earlier, we had shown you the trapezius with shrugging of the shoulders and being able to retract the shoulders for the rhomboid muscles. We also discussed performing the scapular winging type examination. We showed you that earlier on this tape. The next portion of the exam, I really want to concentrate on evaluating the rotator cuff, looking for shoulder bursitis. Another term for it could be rotator cuff impingement syndrome or rotator cuff tendinitis. The very first test we'll look for is looking at the supraspinatus, since the supraspinatus is one of the most commonly injured tendons in the rotator cuff. The supraspinatus test, or the Jabbour test, is with taking the arm and forward flexing it, and sometimes usually at about this level of forward flexion and internally rotating the shoulder causes the patient pain. You can look at their face and see if they are wincing at that point because of pain. In regards to checking the infraspinatus tendon, the shoulders are held to the side, and we would ask the patient to externally rotate against resistance. Again. And again, if that causes pain, usually that's due to the infraspinatus tendon injury at this level. In regards to the subscapularis tendon, basically we would ask the patient to perform a lift-off test. Let me have you stand up, Dave. And basically, if you could turn around this way, we would ask the patient to basically lift off their arm away from their back, and that's usually done again, also against resistance. Go ahead. And that also can evaluate the subscapularis tendon. The subscapularis tendon is an extremely infrequently injured part of the tendon of the rotator cuff, and it's definitely difficult to evaluate sometimes, but at least that's one more exam that can be performed to look at rotator cuff pathology. The next portion of testing the shoulder muscles is looking at deltoid strength, and that's by holding the shoulder in abduction, and you could see the deltoid attachment across the acromion here. If there's been any problems with deltoid detachments, for example after rotator cuff surgery, you would see major drooping of this deltoid in this area. The other problem with the deltoid could be weak, sometimes because of axillary nerve injury, which is the main motor innervation to that muscle. Okay. The next portion of the examination on muscle testing for the shoulder is looking at biceps strength. Again, asking the patient to keep the elbow flexed or resisting basically extending their elbow while they're holding the elbow in a flexed fashion. The musculocutaneous nerve is the innervation to the biceps muscle. If there's any weakness in this area, it's sometimes due to loss of innervation from the musculocutaneous, which can occur after anterior shoulder dislocations. Also, sometimes we would see significant drooping of the biceps muscle in this area. If there's been a long head of biceps tendon rupture, the muscle would have kind of a balled up appearance here. Thank you.